Hello, everybody. I'm Ron Waksman. This is CRT Online. We're doing the COVID-19 series, and I have with me three esteemed researchers and running CROs and investigators and clinical trialists. We have a lot to talk in 30 minutes, so let me introduce Dr. Roxana Mehran from Mount Sinai, Dr. Greg Stone from also Mount Sinai now, and also running the CRO at CRF, and David Kandazari for Piedmont system, also director of the research in interventional cardiology and maybe beyond. So welcome everybody.
Thank you, Ron.
I see everybody is healthy, which is a good thing. So hopefully no one got the COVID and no one will get the COVID. That's the most important part. And maybe I'll start with you, Roxana, if you can tell us what's happening at Mount Sinai. Yesterday I talked with Samin a little bit about the cath lab activities, but how this is all caught you in the midst of clinical trials and running trials, I mean, and how do you cope with it?
So obviously this has been an incredible, unprecedented pandemic that has affected everyone, not just, the patients, of course, the healthcare providers, but importantly, the non-COVID patients as well, and their care and their participation in research. There's been, I would say, about 80 to 90% reduction. We're really down to a very, very small percentage in our lab where we would do 60 to 70 cases a day. Just today, I checked because George Dangus is there. He let me know there's about 6 or 7 cases, and those are all really urgent or needed cases that are being done. So there's been a tremendous reduction in the volume of the cath lab, and that's really across the board, but especially in New York, where we have such a huge density of COVID positive patients. Our entire hospital, for a very long period of time, we're now starting to change and open up some of the non-COVID wards and preparing for bringing in our non-COVID patients for their cardiovascular care. But our hospital, for the most part of the last month, has been about 80 to 90% occupied by COVID positive patients. We've treated and discharged over 3,300 COVID positive patients at the Mount Sinai health system, which is tremendous. So if you can imagine, the impact has been unprecedented. So as a result, there's been hardly any research going on. And one of the first parameters that came out is the non-essential work. So we stopped, and for protection of both research personnel, as well as the patients and the healthcare providers and the healthcare team, we basically stopped enrolling in our cath lab for ongoing research activities. And that basically started on March 15th. So it's been over a month with absolutely no research activity.
So we'll go back to how do you handle this. Maybe, David, you're on the other side in Georgia. It's a little bit more light with your governor. I think you had the stay home, the latest, and now you're almost releasing. So is that a different story at Piedmont?
Not terribly. We're still, at least by modeling and by our own estimates with regard to hospital admissions, by no means have any confirmation of plateauing with this virus. Atlanta, along with New Orleans, of course, have become the epicenters for the disease in the Southeast. And one unique aspect that has occurred out of this in a very positive fashion has been that the three major healthcare systems in the Atlanta area have a daily call, an operational call amongst their leadership groups to share best practices, to share experiences. And so far at present, the number of patients who are in the hospital COVID positive or high suspicion COVID patients has been relatively stagnant. And even just last night, looking at the numbers coming into our Piedmont Atlanta Hospital, the number of patients coming into the emergency department at least still seems relatively constant. What, like Roxana, in our cath lab experience specifically, across all of our healthcare system, we've reduced to very urgent high-risk cases, and therefore coincident with the reduction in elective cases, including structural cases, principally our research as we knew it has declined considerably, but in a unique way, just as there are heroes showing up at work every day in our scrubs and you all taking care of patients and many, many others, that there are heroes in research too, because our research focus in our healthcare system in Atlanta has shifted from a stent trial or a balloon lithotripsy trial to instead one of remdesivir or hydroxychloroquine or proning patients or plasma, convalescent plasma. And what's really emerged out of this experience, as I shared with my director of research services, whom I told her she's really a hero out of this. She's worked tirelessly over 24-hour periods to make sure that EINDs were completed for a compassionate use access for antiviral therapies for patients. Our research coordinators, to a large extent, are working out of home, working remotely, appropriately so, but some of them actually are going into the hospital to still collect information on these very sick patients. And so out of this crisis, and we'll talk about this perhaps more in this discussion, but I think a lot of creative and efficient ways of doing research have emerged. We've seen remarkably quick turnaround times from our institutional review board. We've seen telemedicine being implemented for patient follow-up in our renal denervation trials. We've talked about ways of sending ambulatory blood pressure monitors to patients, both in the US and abroad as well. And even talking about, in certain trials, doing site-based or, WebEx-based site training and initiation as well.
So maybe Greg, as someone that runs large trials and also head of a CRO, I mean, how is that impact a CRO, and what creative ways you are doing to continue some of the research with these challenges?
Sure. Well, first, just to clarify, I don't run the CRF ARO. We call it an ARO, an academic research organization, and I don't actually run it, although I provide a lot of guidance to it. So Ori Ben-Yehuda is the executive director of the Clinical Trial Center. But obviously, it's created tremendous challenges. COVID-19 has created tremendous challenges for AROs, for CROs, for sponsors, for FDA, and for the entire clinical trial enterprise. For the most part, non-COVID-19 related clinical trials have pretty much ground to a halt. I would say probably from what I know, about half of sponsors have either totally shut them down, basically put a pause on enrollment, or are selectively allowing some patients to be enrolled in geographies that have low rates of COVID-19. And of course, you don't want research personnel to contract the virus unnecessarily. You don't want patients to contract the virus. And of course, if patients do get infected, that's going to create a huge confounder into the outcomes of that trial. Such to the fact that now a lot of trials are creating new codes for COVID-19 infection in case report forms. Some are starting to institute routine COVID-19 PCR testing among patients that are in their clinical trials, and other ways to respond to this. So I would say that in general, though, enrollment in non-COVID-19 related research, trials has, dropped by 90% or 95% or more. And of course, inpatient follow-ups, echoes. Obviously, we're not doing routine echoes anymore, even research-related echoes. In-person follow-ups are not being done. FDA has provided 2 different guidances now on how to deal with research when you need protocol modifications, et cetera, and when remote or electronic monitoring can be allowed, how to prolong the windows for follow-up, et cetera. And they're being very, supportive of what needs to be done. But nonetheless, it's a huge challenge for AROs, for sponsors. It means patient enrollments are down. It means, there's risks to the quality of the data. There's obviously financial implications to all people involved. This is pushing back timelines for all planned studies. Just about the only good thing I can see coming of it is that it's giving a lot of cardiologists, there are a lot of cardiologists who have a lot of time on their hands, believe it or not. And some sponsors do as well. And so it's giving us a little bit of time to actually plan future trials, although of course those are all the implementation of all those are going to be delayed until we see how many more months it takes to get beyond our current situation which I think is going to be in the 3 to 6 month range at least.
So let me just put back on one question and then back to Roxana. You know, most of the large studies are 50, 70, 100 centers. Not all the centers are effective if you look at the map across the US. So would you recommend right now to shut down all the enrollment or just to go state by state, and especially when we're talking about some opening elective cases soon? What would be your recommendation? I mean, maybe I'll start with Greg and then Roxana.
Yeah, well, again, I do think that in the height of the pandemic, I think it was smart to basically shut down enrollment. I think it was the responsible and ethical thing to do. Although, and I know that most companies have essentially done that or markedly curtailed enrollment. But I do think that as the country starts opening up again, I do think that we'll be able to selectively start opening up enrollment. And of course, some countries are less infected than the United States and are in different phases of the virus. But I think it's going to be a lot slower. Everything's going to open up a lot slower than everybody would like and probably would anticipate. And I think we've got to be, you know, very careful and very cautious to not expose unnecessarily people to this infection, and also not to corrupt the data from the clinical trials, you know, that we're conducting by having high-risk patients who contract COVID-19, who therefore are going to have so many extra complications and even mortalities, which would markedly skew the data.
Roxana, you want to comment on that? And how do you deal with the patients that you need to follow them up? I mean, you have some trials that are going on.
Yeah, so we just instituted a letter in line with what Greg just said, because we're extremely concerned with close to 50,000 deaths in the United States from COVID-19, which is mostly in adults over the age of 45. You can imagine that there will be a cross overlap of some of these patients who are in clinical trials. There has to be. And in our, some of the trials that we're running, like in the Zions Short DAPT programs, just yesterday, I implemented that we go forward with a new, as you said, Greg, with a new COVID-19 related death rather than a cardiovascular mortality, for if there is evidence that the patient did have COVID and went to the hospital, et cetera, and actually calling that out. And we're going to see that. But I want to come back to David's point. There's a huge silver lining in this, in how we're conducting our clinical practices, but importantly, our research work. For the first time in my own institution, I began to see something I brought in and implemented 10 years ago in using electronic health records to inform registries, which I worked for 2 years on my own. And now I saw that in a snap of a finger, the entire health system came through, and they've set up a prospective COVID registry of every single patient in COVID. And the data are fascinating, and they're grabbing the data on a real-time basis and figuring out, and the reason for it was to figure out how to cope with the volume, understanding the number of days to intubation so that they can see the number of admissions and make predictive models to prepare for intubations and ventilators. But as a result, it's been an incredible way of bringing everybody together for real-time data collection, real-time across-the-board collaboration between infectious disease, cardiologists, pulmonologists, intensive care group. And we're seeing the journals flooded with a lot of data. Unfortunately, most of it is not very well controlled, not well done. It's quick. And I think now the New England Journal, as of yesterday, has brought up the bar. It's going to be very hard to get papers in because I think they are having some remorse. But having said that, I think it has brought the community of researchers together for us to think outside of the box in a more of a using technology to capture clinical events, to do follow-up, to bring data, real-time data together.
As I shared, Roxana, in one of our meetings this morning in the hospital, that this has given us new meaning to evidence-based medicine, or the lack thereof, in the contemporary environment. I mean, we're practicing in an area of no man's land with regard to this illness, and it's quite remarkable for me to see in our institution the wide variability based on an individual clinician's interpretation of the data about what therapies are being offered to patients versus being reserved. And just to go back briefly too to the silver lining in this as well, you know, for us, and I'm sure at your institution too, the research continues to evolve with regard to contracting and planning, and as Greg described, for trial planning as well. And I think that maybe just as many think that telemedicine may still have a legacy after this this current situation in clinical practice, that we may have some telemedicine clinics still extend beyond this, beyond COVID after that's resolved, that we could see this perhaps as a very efficient method for follow-up in clinical trials as well.
Oh, there's no question about it. I mean, after, you know, look what we're able to do right now, just in a matter of a few, 1 or 2 days of planning for us to have a conversation. And I already have had several e-visits with my patients, and at the very least, you can see them, you can get an idea, and there's no reason to miss out on follow-up. And I think this is going to be the future. There's no question we're learning a lot from this unprecedented times.
But one thing I will say is that a lot of our, especially more elderly patients, do have tremendous difficulties with telemedicine. I mean, a lot of them don't have the appropriate devices, and even if they have the devices, they can't learn how to use them. I remember my mother could never learn how to use a microwave oven. Okay, and we're going to get to that phase soon where we can't learn to use the new technology. So, you know, I think that telemedicine is going to have a role for people, you know, for the appropriate type patient, but I still think there's going to be nothing like laying hands on and looking in the eyes of somebody and getting the nuances from their body language and from an actual physical examination.
So well, let me just ask you another question, which is related to what we're seeing. I mean, the FDA obviously cut a lot of red tapes with approval, mainly for COVID-19, but we always said there is a precedent, and things are changing in terms of off-label use, in terms of trial designs that are approved within 30 trials designed, like approved within like less than a week, et cetera, et cetera. So how much of these can be utilized for our neck of the wood in terms of interventional cardiology? Dave, what do you think? You had some engagement. You think the FDA is going to be transformed to do it beyond the COVID-19, or it's going to be just COVID-19 related?
I think especially for follow-up of patients, as Greg referenced, there have been at least 2 documents that have been imposed and supplied by the FDA. And as you know, Ron, we've had discussions with FDA about guidance in the setting of COVID. And in many ways, I think the FDA has still taken a more conservative approach, at least in my limited experience with certain trials, with regard to collecting information related to COVID-related adverse events. But, and I think everybody, as Greg mentioned, most practitioners who are in the front lines really see it as a goodwill sign that many trials have been suspended or paused, at least in their enrollment, by the sponsors directly. But with regard to the FDA, in terms of turnaround times for approval or expediting approval of technologies, and at least in our space of cardiovascular medicine, I don't see that terribly changing.
Yeah, I would agree with that.
I wouldn't see it either. I agree with you.
Yeah, it's something, well, I'll try to bring the FDA to this panel as well to see what they can come with in our field. The other thing that I think is interesting that you mentioned about papers. So as an editor of a small journal, I can tell you, people have a lot of time. So they write papers, and we had like a double or triple the number of submissions that we had. And also the turn time to review is actually getting shorter. So there are some free time for interventionists that they are utilizing them. And again, I think what the New England did in terms of publishing these small registries with no control just because of COVID-19 there, it's also happening with the Lancet. We submitted the paper to the Lancet. The answer was, we're too busy now with reviewing COVID-19. We just don't have time to even look into your paper. So there is a whole issue that impacts the whole academia. And I don't know how long that's going to be continued. But
I can tell you, Ron, that the three major medical journals and the three leading cardiology journals are all getting up to 100 COVID-19 manuscripts a day.
they're saturated. They just flooded with, and most of them are probably anecdotal. So your thoughts about big data, because at least two of you are big believers on big data, and probably Dave as well, but you basically engage with it. One of the things that you look in all those trials that are coming, there is really not centralization of the data. I mean, you can look at your own EMR, Roxana, with the Sinai network, but again, look at all those trials, probably over 300, 400 trials going on right now. And most of them are underpowered. Most of them do not have a control. Most of them have so many subsets, and there is really no one that championed the whole thing. So are we missing something like that? I mean, is there any advice that we can do? I mean, any thoughts on that direction?
I think it's a really missed opportunity not to use this particular venue with such large numbers of patients who are coming in at such a huge volume and such a fast pace. To be able to, with no really proven therapies, not to engage in a randomized prospective study. But at the same time, I think it's such a shocker as far as the volume and the workload on all of the healthcare providers, that implementing yet another thing on top of what is going on is almost very, very difficult for people to grasp on. And so what you're seeing is this, the provisional use of all kinds of drugs with no proven results in just sort of kitchen sink fashion on pretty much saving a life that might be, 1 week it's TPA, another week it's low molecular weight heparin, and then on top of that, Plaquenil and AZT, and now with the convalescent serum. And I thought that was going to be at least a prospective randomized study, but no, it's being given to the patients at a certain level, and they're just looking for a response. So everything is becoming a pilot for a hypothesis generation for prospective later on studies, but I think we're missing the boat if we don't do something.
What we've done, Roxana, at Piedmont is in an unprecedented way of hospitals across different systems sharing their data. As you all know well, there are large registries that are ongoing for acute coronary syndrome, COVID-related patients, one in North America, and Greg tweeted about another international one today. But specific to the management of COVID patients, there is in the sepsis domain a great deal of application of artificial intelligence, of machine-based learning and neural networking to help inform decision-making for patients with sepsis. And we've pooled our data along with other hospitals and are collaborating with another group who has time on their hands, some brilliant engineers at Georgia Tech down the road from us here, in creating these models that might help inform decision-making for mechanical ventilation, for which patients can or cannot go home after presenting to the ER, among other dilemmas.
Yeah, those are great. We're doing all of those as well. Predictive models using machine learning neural networks. That's exactly what's going on. Our population health group is doing that for the entire system. But what I'm talking about is in understanding treatment modalities and moving forward with the prospective randomized studies, and we're not doing that. There are some.
There's certainly some randomized trials that are.
There are some. I think we can do better.
They're still being planned. But.
Yeah, the big ones are going to come later on. The problem in the interim, we are like fed by a lot of anecdotal medicine, and the problem, there will be mistakes, and people will do mistakes. Nobody wants to randomize to placebo, randomize his patients to placebo. So we're breaking all the rules of research, and no one is trying to hold it. And I can understand, but I hope it's not going to be turned to be the norm in the future. So somewhat we have to be cautious about how this is not going to be the new norm of how you're doing trials and how you treat like something that you feel very passionate that you want to treat the patient.
Well, it's really important that we don't break those norms of research, and I am distressed in seeing what's going on, because there's no doubt that every single therapy we're talking about can have harm. and can worsen the outcomes for these patients, whether they're antithrombotics or whether they're hydroxychloroquine and AZT, or remdesivir, or prone ventilation or steroids. I mean, we have to do this right if we're going to get answers that are going to be durable. And it's not like this disease is going to be gone in 2 months. It's very possible this is going to become seasonal again, and there's always going to be some background COVID-19, much like influenza, but with greater implications. So we've got to know what we're doing here.
Maybe the last segment that I want to talk to you about, are there any opportunities, and how do we get to continue the research post the pandemic? I mean, we hope that, again, in the summer, this is going to be coming to levels that we can return almost to normal activities in terms, I mean, the biggest issue, patient doesn't want to come. You can beg the patients to come. If we're not going, and that's one of the issues with telemedicine that I see, that when you train them to go telemedicine and you give them the option, the patient would say, why in the hell I'm going to come to the hospital to be in any risk to contract the virus? So this is going to be taking some time, but the question is, how do we get out of this? I mean, should we plan different ways to conduct research for the next year, or we just have to wait a year until everybody's going to get vaccinated and it's going to be disappearing?
I think this is a really good question, and I actually think that we're going to have a new normal for a while, which is going to look nothing like what it was before COVID. And until we have vaccination and some possible cure, I can't imagine that we're going to go back to where we were before. It's kind of I was telling some friends about how we don't even think about how different it is today after 9/11, going to the airport and going through all those lines and all of those things. But before, we used to just walk in and go on into the, it was a complete different way of how we were traveling. And now we don't think anything about it, even though it's changed tremendously from pre-9/11 to post-9/11. And in some ways, I think there's going to be a pre-COVID era and now a post-COVID era. And as Greg said, I don't think this is going away anytime soon. There's always going to be some of this virus somewhere, living somewhere. And we have to figure out a way to protect ourselves, our patients, and figure out a way to open, but it's not going to be open business as usual. It's going to be a whole new normal.
But, I actually call it the new abnormal, not the new normal.
Yeah, the new abnormal. Yeah.
And we've obviously already seen that there's about a 40% reduction in the number of STEMIs that are coming in. And we're starting to get more information that it's not that those STEMIs are just not happening. It's that people are having their STEMIs at home, and the ones that are coming in late, often now with mechanical complications of AMI, things that we haven't seen in a long time. And I think that once we get this tampered down, I mean, Roxana, you and I are living in the epicenter of the disease right now in the world. And David, you're not far behind. I do think, though, that there are a lot of communities where people are still going to the beach and to the mountains and are still showing up at hospitals. And they're going to open up much faster, and they're going to have less of a long-lasting impact than we're going to feel. So I do think that, like you said, I mean, when I grew up, my parents would, come to the gate, and we'd meet my grandfather when he got off the plane at the airport, right? And you don't even remember that happened anymore. Now there's the new normal in airports. We're going to get to a new normal in society, the way we treat medical diseases, the way that hospitals protect patients, et cetera. And I think we're going to get back there, but it's certainly going to take well more than a year before the country gets back to normal.
Yeah, I see research for us paralleling the startup for all elective procedures, whether it's imaging or clinics or the cath lab as well. And I think that the head of CMS said it best, that this will not be a flip of a light switch, but more like a sunrise. It'll take time.
But I do think that what we can contribute is to encourage the patients to take care of themselves. And when they have symptoms, they should still come to the hospital, and we should give them a safe environment, because many of the people that die, they don't die from COVID. They die, or maybe not directly from COVID. They just die because they're sitting on their MI for 48, 72 hours. They're sitting on other symptoms. They're not being treated for the other diseases. So we have to make something there that would be appealing to the patients, and they would trust to go back to to the hospitals to get the care. If they're not going to do that, I mean, forget about the research is one thing. I mean, one do research, but you know, the mortality will continue to rise, and everyone who's going to die at home is going to be considered to be a COVID death. I mean, you're not going to check his blood after you found him dead at home. So I think that's something that we should probably gather data, and that can be done maybe on a mega data to see how many of those patients really, what's the consequences of not coming to the hospital, because patients are afraid to come to hospital to get the virus, but they for somewhat ignore the fact that they can die from just not coming to the hospital.
So the collateral damage of COVID-19 on heart disease is going to be astounding, and that's something that we're going to start to see. I saw a statistic and I tweeted out that this last month there were still more heart-related deaths than there were COVID-related deaths, but COVID was right up there as number 2, extremely close to heart disease, and it was looking to overcome and go on top of it for a while. And you constantly think, just last week they added 3,000 more deaths in the New York State that were sudden deaths or patients found at home dead that they called COVID. But who knows how many of those are non-COVID sudden cardiac deaths that we just no longer see because the patients aren't coming to the hospital. It is going to be, I call it the collateral damage of COVID-19, not just for the COVID, but for the non-COVID care as well, including surgeries, cancer treatments, all those things that are being disrupted because of this.
So maybe our time is almost up. Let me ask every one of you to give like his final thoughts and what is on their heart, and how do you see we getting out of this? So we'll start with you, David.
Well, I think that despite some of the statements from our governmental leaders, though, that the science is the best determinant here, and we're still not past this in both of our regions by any means. And my biggest concern is really for on a public health impact, the welfare and safety of people to still continue to take the same measures that they've been doing to let us get past this and let us get control of our resources that are available for us in our hospitals. So with regard to research, though, I would just summarize by saying it's been a complete shift for us, just as it has been in every other way in our lives, but now towards one of COVID-related research for this time being. We found new efficiencies in research. I've recently read a comment that all research is in turmoil by one leading investigator in the United States. I don't think that's the case. I think things are suspended for the way we were doing it, and we'll see a new norm emerge out of this.
Thank you, Greg.
Yeah, I mean, I think that, you know, we can't be penny wise and pound foolish. This is going to reverse itself. We are going to get this under control, but the effect that this is having on every aspect of society is staggering. And if you look, I do believe we've reached the peak. If you look in New York, the curve now for about the last 5-6 days is definitely flattened and is actually decreasing. We've seen it at the Mount Sinai Hospital system where we were running up to about 2,200 inpatients, COVID inpatients per day. Now we're down to about 1,500. So it is decreasing, but it's still going to take us another couple months until we've got this 70, 80% tampered down. It's not enough to stay at the peak and then open up things again, whether it's research or the entire economy, et cetera, or we're going to rapidly increase again. So I've got no doubt this country is strong, the economy is strong, all the foundation is still there, but everything's got to be put on pause, and we just got to be patient so we can get this, you know, totally under control. So when we open back up again with all of our functions, whether it be research or patient care or Wall Street or businesses, movie theaters, restaurants, et cetera, that we don't see a rapid increase again. Thank you. Roxana?
I think both Greg and Dave have put it in a very positive way. My only, and I'm hoping that many more than just the scientific community watch this, as tattoo parlors open up in Georgia.
Yeah.
I'm hoping that I'm hoping that we continue to listen to only one authority, and that is science. Not a person, not a government, not a hearsay, but really following science. And at the moment, what we have learned and what we have seen, and despite all of the hardship that we're all feeling, the social distancing has been the only treatment for COVID-19. And there's no question that we absolutely must follow that. The worst thing we could do is to go back and as much as I want to get out there and start seeing you all in person and having our personal touch and our personal meetings and our exchange of information, we need to sit back, as Greg and Dave have said, be patient, and not rush to things, because the last thing we want to do is to open the doors and then be caught by another surge, which could keep us home for 2 years or more until we have a vaccination. I agree that there's a silver lining for all of this, and we discussed all of that. And most importantly is the fact that we're all in it together, like they're all saying. And as long as we keep this bond very, very strong, continue our exchange of information, our collaborative, whether it's across Zoom or emails or what have you, I feel very, very strong that the future is bright and the sun will shine again, and we will be back to this new normal. We will be back in research and in scientific investigation. Thank you, Ron, for doing this.
No, and I will say one thing, that it's all about our patients. And we do have to take care also, not about the COVID-19 patients, but all the array of patients. I mean, we know aortic stenosis, if you don't treat it, mortality rate could be 50% in 1 year. We have to take care of our patients across the board, not just the COVID-19. And we have to find some creative ways to do it while we're watching our healthcare, ourselves and everybody else, not to get to end this pandemic as quickly as we can. So I really like to thank to all of you. We may do it again in few months. I mean, hopefully under better consideration and situations. And let's keep the research. We cannot compromise it. I think there is one consensus here in the panel. We cannot compromise research integrity because we will regret it. If we'll do it, we'll do mistakes and we'll regret the mistakes, and things will come even stronger that there is nothing that can be compromised on research. So thank you very much. Stay safe. Stay healthy, and we'll see you hopefully shortly in person.
Thank you.
Thank you, Ron.